Hey everyone, welcome to the Couple Nurses podcast with your hosts Peter Findero, myself, Matt Solarchik. This is a podcast where we tackle current health news and hot nursing topics, one conversation at a time. Thank you everyone that listens, follows. We see those 5-star ratings. We just kind of read some right before the show. We got super pumped up, so we appreciate it. And if you find any value in this podcast, please share, please give us that follow, share, review, because you have no idea how much it helps us. And of course, it motivates us to keep producing this high quality content, and that's why we have this energy right this moment to deliver another episode. Pete, how you doing?
I'm doing good, man. I'm super sore from today's activities, but actually I'm not super sore. I'm super tired from these activities. Tomorrow I'm gonna be super sore.
Hell yeah.
I got a bunch of bruises. I got bruises on my forehead, my arms. Everything's bruised up. But guys, today we got a great episode for you. Per usual, we're gonna talk about some drugs. Unfortunately, not the fun drugs, but some more serious drugs. Drugs that keep you alive.
Can we get to the drugs afterwards?
Maybe on that loud.
That loud.
Maybe that loud,
okay.
but we'll see how far we're going to go, guys. So today we're going to talk about the most common vasopressors we use in the ICU, those being norepinephrine, epinephrine, phenylephrine, vasopressin, and dopamine. This is a very common class of drugs that we use, vasopressors, for like if you're on the floor, on any kind of unit on the floor, and let's say there's a rapid response called for hypotension, they're probably going to give you a pressor, and as soon as they give you the pressor, guess what? You're going to the ICU. Just because these medications are really critical and they need to be managed properly. It's a titratable drug, so it's not just like you're giving it just a one dose and it's doing its thing. It's not like a beta blocker where you give one dose and you give the next dose like 6 hours later. This is a continuous running infusion of medication that keeps your blood pressure up. They don't have a very long half-life. That's why it's a continuous infusion, and it's titratable and requires very close monitoring.
And that's why, let's just say you don't know what pressors are, or you're somebody that's non-nursing related. This information can be for you as well, because a lot of times we're on the phone with family and we tell them, oh yeah, they're on life's sustaining medication or they're getting pressors. And a lot of people don't know what that means, but we're literally keeping your body alive. If this medication wouldn't be infusing through your veins, you wouldn't be alive, because it's vasoconstricting and helping maintain a blood pressure to perfuse your organs. Right.
Yeah. So vasopressors' main job, what they're mainly used for, is to keep your blood pressure elevated. It's like Matt said, it's used so it depends on your age. We'll use either like at systolic pressures or MAPs. A lot of times with our younger crowds, we used to like to use MAPs because they're a little bit more accurate. So basically, vasopressors is a type of drug that induces vasoconstriction and it keeps your MAP elevated. A lot of people get these confused with like inotropes. Inotropes, they don't constrict your blood vessels. They actually promote contractility, so it makes your heart beat stronger and harder. And keep in mind that some of the medications we're going to go over are going to have both effects on contractility and also vasoconstriction. Yeah. Some medication we're going to go over some like different like alpha-1 adrenergic reaction, things like that. And some of these drugs actually work on different parts of the body and promote different kind of receptors. So some of these drugs actually are going to increase contractility, and they're also going to increase blood pressure and vasoconstriction.
Yeah. And normally, any single time you see these drugs, they're in the ICU, or they're going to be started during a rapid response, and then that patient is going to get transferred to ICU for further closer management. And if you're wondering, those that don't know, why do we start patients on pressors? So yes, low blood pressure. Why? Sometimes it could be systemic shock from an infection, bacterial infection. Lactate builds up, bacteria vasodilates, and your blood pressure goes down. These drugs have the opposite effect. They constrict. The way I like to kind of like imagine it for those and to like dumb it down is, think about pressors like a plumbing system. So you have the heart, which is the pump, and then all your veins and vasculature is the pipes. So, if the pipes are way too large, there's too little volume in the body, the heart is working very hard and the pressure in the pipes is very low. So we have to, correct that with the pressors, and that's exactly what we do in the ICU.
Yeah. So what you'll be doing basically is fitting that giant pipe with a smaller, more narrower one, so you get more force in it. And this is very interesting. I wish we looked up when they were invented, because like people were dying from sepsis like a long time ago because they didn't have vasopressors, right? Yeah. So imagine what kind of revolution vasopressors were for medicine, right? We, instead of dying from sepsis because of hypotension, now we have these vasopressors that can promote an increase in blood pressure, increase MAP, increase systolic blood pressure, diastolics, and make you actually live longer.
Yeah.
Unfortunately, not unfortunately, but fortunately, they make you live longer. So then we could hopefully combat that infection. Once that infection clears, body fights it off, then you're not going to need those pressures anymore.
Yes, sir.
Because it's a whole cascade of issues with vasodilation when someone is septic and has a bloodstream infection.
Yeah, and like sometimes like in the ICU, you're turning these pressors on and off, meaning, let's just say the patient's there for a week. Sometimes they're on it the first 2 days, they get off, something else happens, you diurese them too much, meaning you pull way too much fluid when they pee out, pressure's low again. And it's this fine balance beam that we're playing to like, keep these patients alive and hopefully discharge them and so they could go home and have a quality of life.
Correct. Yeah, so the first thing we're going to touch upon here, guys, is these vasopressor considerations. So there's different receptors that these vasopressors work on. The first one is going to be your alpha-1 adrenergic receptors, right? So those are located primarily in your skin and your GU tract. And ultimately, these medications that affect alpha-1 adrenergic receptors, they're going to decrease blood flow to those organs that we went over, so your GU tract and the skin. So activation of these receptors will result in vasoconstriction and increase in peripheral vascular resistance and systemic arterial blood pressure. So basically, you're going to increase your MAPs and you're going to increase your systolic blood pressure. And then you have the alpha-2 adrenergic receptor, which contribute both to control of sympathetic tone and to local and regional blood flow in the peripheral vasculature. So this is actually like these sites are basically located right where alpha-1 sites are in your body. And it's crazy how these things like work like this. This is like straight down to like the most minute scale.
Yeah, and it's chemicals and it's receptor sites that like affect things, like it's mind-blowing to think about. Next we have beta-1 adrenergic receptors. So think of beta more heart related. So it works on the SA node, the AV node, and what happens is it basically constricts heart muscles. And it activates, what it does, it creates a chronotropic effect. So it actually increases heart rate, beta-1s. And automatically that helps with contractility. So that has an inotropic effect, meaning better squeeze. And then we have beta-2 adrenergic receptors. That's more located in the GU tract, the bronchi, uterus, pancreas, also muscles of the cardiac and blood vessels. So this actually helps with smooth muscles. And I think at one point it has like I think beta-2 is also on dopamine, correct? Where low doses it helps with vasodilation, helps with like what's it called, perfusion when it comes to the kidneys. Right. Also, it has the effects of cardiac contractility in higher doses.
Yeah. And the fifth one we have these are dopamine receptors. So what's cool about dopamine is actually it's a precursor to epinephrine and norepinephrine. So if you don't have any dopamine, you can't make epinephrine or norepinephrine, right? It's pretty crazy. So activation of dopamine receptors are going to cause vasodilation, increase myocardial contraction, and then increases cardiac output without changing the heart rate. So a lot of times in the hospital, people with like cardiogenic shock, things like that, heart failure, they're put on dopamine at low doses, and sometimes we go to higher doses for some of that contractility help. And it's actually interesting to kind of understand why we actually do this and what kind of receptors actually works on to fully understand why we start certain pressors over others.
Yeah, and if we're starting these pressors, things to keep in mind, in the ideal condition, you always want a central line because they have a toxic, that you could basically lose a limb sometimes if it infiltrates the IV and it's, going into the, extra spaces. So ideally, central line, if you can't get that or the patient's really sick, let's just say you're in a hospital where there's no overnight intensivist, you have an NP, you got to do what you got to do. So some places, I think the policy is you only want a 20 gauge IV. The place that I worked at previously, they wanted a 20 gauge IV and they wanted it in the AC or above. So antecubital, where you kind of bend the elbow, that's where they want a 20 gauge or anything above, man. So anything in the forearm, hands, huge no-no.
Yeah, because they're so vasotoxic.
Yes.
And when it's also really toxic to your vessels and your skin is going to be amiodarone. It's not a pressure, obviously, but still, when that infiltrates, that causes a lot of damage. Some people actually lose a limb because of amio, especially if like you're down in like a med-surg floor or people have like 6 patients and it's super busy. That's where you kind of find that because sometimes you don't have time to check on a patient as often as you want to. So a lot of times if the IV isn't working properly, then amiodarone goes in the skin and people have like skin rafts due to it and actually limbs actually taken off because of it.
Right. And you want to flush your line and check if there's a blood return. Usually if they're 20 gauge and below, like a 22 gauge, you're not going to get a blood return. So just use your nursing judgment. whether you want to start a pressor before they start a central line. Yeah, it gets a little bit complicated. And let's just say, worst case scenario, if you're wondering what happens if there's extravasation, meaning the ingredient, or I'll call it ingredient, let's just say the pressor leaked into the vasculature. What do? We actually have like an antidote. It's called phenylephrine, if I'm correcting it or if I'm pronouncing it right. And you basically mix it with a little bit of normal saline, you dilute it. And the way I administered it, it's intradermal. So I took a insulin needle and I was just sticking it all over, and I was kind of like injecting little doses of this medication around the site to kind of reduce the toxic effects on the skin.
Yeah, same when I had the ammo infiltrate, we just draw it up in like an insulin syringe, just put it around the area.
Was it the same drug? Do you know?
No, it was a different drug. Ammo was using something else. I'm not sure.
Okay, so there's antidote for different things,
Yeah,
just
there's
like heparin and
correct.
all that.
Yeah. Yeah. So the first drug we want to go over, first pressor, is called phenylephrine. Norepinephrine, it's also called, or Neo for short. And this pressor is kind of like almost like your first line pressor. It lasts longer than epinephrine. So it's action on the heart contrasts sharply with that of epinephrine. Like I said, it's a little weaker, so it's not gonna have the same effects. Like when you think of a pressor, you're gonna think of elevated heart rate, right? Or elevated heart rate and elevated blood pressure. That's what these base medications are used for. So like the effects you're gonna see with Neo with phenylephrine, it's Neo causes a rise in systolic and diastolic pressures. What's nice about this drug actually compared to other pressors is it doesn't actually increase your heart rate as much.
Yes.
It does sometimes, but not very often.
Yeah.
So sometimes you might get like reflex bradycardia. You might have to give atropine. And sometimes if your patient has low blood pressure and you start him on levo and he gets like tachy or gets some tachyarrhythmia, some PVCs, sometimes physician might switch him just to Neo at a higher rate because levo is stronger. So you're gonna need to start the Neo at a higher rate and then leave him on that. So they'll be okay with a higher rate of Neo than a lower rate of levo, just because you don't have that risk for these ventricular arrhythmias or kind of tachycardias you're going to see.
Exactly. Neo is like one of the weaker pressors of what I say, because it doesn't work on beta adrenergic. And let's just say if they were to choose levofed over neosynephrine to see which one they would give in a peripheral IV, they would choose this one. Neo is less toxic if it were to infiltrate compared to the other drugs. So like in my previous hospital, if it was peripheral, we only could start this drug till we get a central line in, then we could switch over to levofed. So yeah, and it's gonna always differ everywhere you go and every single place you work. But that's what's so cool about travel nursing. Another little fun fact, right? You get to see all these different atmospheres and how they operate, and then you could just have this experience to share to the world.
Correct. Yeah. Yeah. What Neo also does is it causes pulmonary vessel constriction, so it actually raises the pulmonary atrial pressure as well. So that's also something to take into consideration when you have a patient like that as a SWAN.
Or pulmonary hypertension.
Yeah, hypertension, things like that. And next up on the list, guys, is norepinephrine. This is basically like the wonder drug, also
favorite.
called levofed. It's every ICU nurse's favorite because it's always there to back them up. Every ICU has it stocked in the Pyxis and the Yami cells or wherever you stock your meds. You're always gonna have emergency levo. You might not have Neo necessarily, but levo is always there and epi is always there out of all of them. So some of the effects you're going to see with levo, its primary role is an activation of the alpha-1, alpha-2, and beta-1 receptors. So you're going to see a little combination of these effects. So the common things you're going to see is increase in heart rate, increase in blood pressure through an increase in cardiac output, and systemic vascular resistance. You're going to see vasoconstriction of the arteries and veins, which is your alpha-1 and alpha-2 receptors. You're going to also see an increase in heart contractility, which is your beta-1. Like we said before, some of these drugs are going to have inotropic and vasopressor effects. It's going to increase blood flow to your skeletal muscle, but it's going to reduce blood flow to your GI tracts, and it's also going to inhibit voiding and your gastric motility. Yeah. That's another thing to consideration, because let's say your patient hasn't had a BM for like 4 days, and you're wondering why. Why does this patient have bowel movement? And he's getting, narcotics, opioids, and now he's on a pressor. That's all going to slow everything down. Yep. Because in ICU and a hospital, you have priority. So before we start focusing on your GI tract, before we start focusing on when last bowel movement was, we gotta act in the acute care setting. So what's wrong now? Blood pressure. So it's fix the blood pressure, fix the heart rate, fix what's ever going on with the brain, then brain or the heart, depending on what unit you're on. But both are is important, right? So we're gonna fix the primary issue first, and then kind of worry about the secondary issues, because there's side effects, but in the moment, your hypotension is a lot more important to us than the side effects of these medications.
Yep. And also, this drug is usually mixed with D5W in the bag. So if you are monitoring your patient, if your blood sugar is elevated randomly, and you're like, oh my God, why is he having high sugar? Well, high dose pressors diluted with this medication, you're gonna get hyperglycemia. So sometimes you want to add your Q4 insulin checks if they're MPO and lower that down. And just to like understand how powerful these drugs are. So I was like in my patient's room with, COVID and stuff, so I couldn't get out and I wanted to switch my lines. I had a central line with 3 ports and I had 2 peripherals, but I had like 6 different drips and some of them weren't compatible. So I literally Y-sided my levofed, and let's just say I Y-sided, there's like 3 mLs in there. I had quad strength levo, so instead of 4 micrograms per ml, I had 16 micrograms per ml. My patient's blood pressure went up from the 90s to the 180s for like 5 freaking minutes.
Yeah.
And I was just like, I was like, shit, man. I'm like, should I turn up the propofol a little bit, kind of lower it down for a little bit, because it's like an art in the ICU. Sometimes you got to play with different medications to get your desired outcomes. But after a little bit, then I seen the 40s and then the 130s, and I was like, I'm okay with it.
Yeah, it's always cool when you have like
An A line.
Well, of course, yeah. When you have A line, my favorite line is the A line. I love A lines. You could draw blood. You have continuous blood pressure readings. Draw EBGs. It's a beautiful invention. But it's always cool to see. It's just when you have a patient that he's on like 2 or 3 pressors, and he's also on propofol, Versed, and like fentanyl. Obviously, you want to get rid of one of those sedatives, but say patient is freshly intubated, post-code, and he's recovering all these pressors and all this sedation. And it's cool how like they become like hypertensive. Let's say blood pressure goes up, and you could increase the propofol and keep it elevated, right? If you really wanted to, or if it drops, you down titrate the pressors. Like it's so cool to like titrate sedation sometimes, because sometimes your patient is like hypotensive, and he's on sedation. Let's say he doesn't have any kind of pressors, but he's just on sedation, right? So he becomes a little hypotensive, and you go down on propofol a little bit, and he rises back up, and it's cool. Because we do sometimes oversedate our patients, to that point where he's a little bit more hypotensive than he has to be. So he's like, low 90s, high 80s systolics. You're just like, I can start a pressure, but let me bump this propofol down a little bit, see what happens, And it's cool how to see the blood pressure goes up by like 10 or 20.
Yeah, so that's like another thing. Like we don't always give pressors for sepsis and shock and all this stuff. Sometimes we're just a patient's on pressors because they're in that conscious coma, they're sedated, and we just need to bump them up a little bit just to kind of, keep them comfortable. Sometimes they're on prop and fentanyl. So of course they want to be asleep when they're intubated, and they want to be pain free. And the side effects of that are low BP, and we correct that with a pressor sometimes.
Yeah, that's cool.
The next one is going to be Vasopressin. And it works a little bit different than all the other pressors because it works on the peptide hormones. So there's V1 and V2. It affects 2 major sites, and it also works on the kidneys. So V1 is responsible for constriction, where it increases SVR, systemic vascular resistance. So that's going to increase MAP. And what it also does is that some nephrologists start these patients on if they have low urine output. So it works on a V2, and that's responsible for regulating extracellular fluid volume. So it kind of activates the kidneys to reabsorb volume back into the vasculature, which in return, more volume, more fluid in the pipes, your MAP is going to go up in your in your blood pressure.
Yeah, it's cool to think when you're a nurse and you see all these pressors, and you finally realize like this raised blood pressure by activating this cascade of things, and then compared to this one where it's doing this, right? And if someone that's like severely fluid overloaded, you obviously wouldn't want to give vasopressin, if he's got like super fluid, like not super fluid, but just a bunch of fluid on, you might not want to give vasopressin because you don't want to pull any more fluid. You kind of want to give Lasix to kind of pull out that fluid into his vasculature and then kind of pee the fluid out. So it's pretty cool to kind of think about and look back like, oh, that's kind of why the physician has this pressor over this one.
And usually with vasopressin, those are one of those pressors you're not going to be titrating as much because it's usually 0.04 or 0.03 units per, is it ml or per hour that's being given. Yeah. So usually with some pressors, let's just say levofed, correct? We're titrating from 0 mics to 20 mics. We'll go down by 19, 18, 15, 16. With vasopressin, it's usually 0.03, and then we just shut it off and see what happens. So it's a little bit different from the other pressors. Going into the last one, the most hardcore one, if you're on this pressor, Probably got to dial the family.
Things
Probably
aren't
family
good.
has to kind of come in and figure some shit out because this is the fourth pressor we add on usually, and shit's hitting the fan. So epinephrine, you see it in the EpiPens when someone's having a allergic reaction, but it's a different concentration. You're also pushing it during a code blue. You're giving epinephrine, and you're also hanging epi because it works on alpha 1, alpha 2, beta 1, and beta 2. So it works on all 4 receptor sites. And it's a drip. It's hardcore. Family meeting, please, because the patient is probably at this point, when you give a fourth pressor, their body, all the blood is pooling in their like from their torso, right, from their freaking pelvis to the chest, and their fingertips are cold. They have a pulse ox on. Sometimes it's reading bad because they're cold. Their cap refills get bad. They have like the modeling before death sometimes. Not every patient makes it when they're on that pressor.
No, and some people get like black toes and the amputation from it.
Yes.
If they're on like 3 pressors and one of them happens to be like epinephrine. Dude, yeah, that thing vasoconstricts super hard. Like your extremities, like that blood just pulls to your heart because you're trying to just keep you alive. And we've had the patient in my prior hospital that was on like three pressors for like a super long time. I want to say I don't know about a month, but weeks, right? And he came out of it with like black toes, like legit, like 8 out of his 10 toes are black.
Jeez.
And it's crazy. Like then we had to put betadine on it. We had to change the dressings on them just because these are some serious medications, man. Like not only are they damaging to outside the vein, but if used for long periods of time, this is what it causes. But this is just part of survival,
Yes.
Like if we're thinking about it, your brain health and heart health is a lot more important than your toes.
And this is the same chemical. I don't know if you want to call it chemicals, but same. Would it be a hormone?
Receptor?
It's a receptor that gets released from your adrenal glands, like during that fight or flight moment. Like when we went skydiving a couple days ago, that's the shit that was pumping through our damn veins. And when I was skydiving, I felt the rush of like these chemicals because I got clammy, my fingertips got a little bit cold, and then my feet started getting a little bit numb because I know I was kind of losing circulation in a way, or I was just afraid of losing my life and jumping out of the airplane, whichever one.
Yeah, probably all of them. So the effects of epinephrine, guys, we're going to see. So first one is going to be relaxation of smooth muscle in a bronchial tree while increasing myocardial oxygen consumption. You're going to have an increase in heart rate and contractility, which is your beta 1. You're going to have vasoconstriction in most arteries and veins, which is your alpha 1 and 2. At low concentrations, it's going to cause vasodilation of muscle and liver vasculature, which is your beta 2 as well. And at higher concentration, it's going to cause severe vasoconstriction, which is alpha mediated. Cardiac output is going to be increased. There's going to be a change in MAP. It's going to be increased. This is beta 2 mediated. And the one thing about this, it does increase myocardial oxygen consumption. So you kind of have to worry about, because your heart is going to get worked pretty heavily with this.
Yeah.
So, watch out for that. You might want to change the ventilator settings to 100% FiO2 at this point.
Right. And so I've noticed also a couple of shifts ago that at work, so patient, of course, COVID and ECMO and all that, right? And they had 2 or 3 pressors on. And usually epinephrine, if you have like 3 pressors, epinephrine is the one you're titrating first. It has the shortest half-life. Also has the most like effects and side effects. So you want to get rid of it before you titrate the levo. With her, they wanted her to have always 1 mic of epinephrine running no matter what, because she had a horrible heart failure. And that was actually helping with the cardiac output because it helped with the contractility. So it's just going to depend on every scenario, what happens and how these drugs are used. It's not always just like we say, like, shit, code is happening. We need to keep them alive.
Yeah, that one of epi is a pretty common thing because I did a handful of times in my prior hospital and I did it a few times here. So that's what's cool about that. Like the patient technically doesn't really need to be on one of epi. It's not a super high dose. I mean, it is epi. It's still like life-saving and critical, but it's interesting to see we're not giving epi for the blood pressure, we're actually giving for contractility. It's cool to think about that. So like in your situation, they want to down titrate on the other medications and leave epi.
It's like it's like the patient's going through something right now, so let's temporarily do this to kind of offload the heart, give the heart a break while she's getting better and fighting her pneumonia and with NARDS.
Yeah, the last one we want to go over, guys, is dopamine. It has different effects at different dosages, so that's why I really thought dopamine was so curious because at certain doses it does one thing, and at other doses it does another
Dopamine
thing.
was curious, or you're interested? You're curious about dopamine.
I'm curious. I was always curious about dopamine.
Yeah. Okay.
It's a curiosity of mine. So like I said before, dopamine is a precursor to norepinephrine, epinephrine. So at low doses, dopamine stimulates the heart and decreases systemic vascular resistance. At high doses, dopamine's vasodilation effects becomes vasoconstriction as there's lowers affinity for alpha receptors binding to dopamine. So the effects stimulates both the adrenergic and dopaminergic receptors. So at lower doses, mainly dopaminergic are going to be stimulated, so it's going to produce that renal and mesenteric vasodilation. And then you get to the higher doses, that's going to have both the dopaminergic and beta-1 adrenergic stimulation, so it's going to produce cardiac stimulation and renal vasodilation. So it's actually really cool. And then if you want to go super high concentration, that basically turns it into a pressor. So it stimulates alpha adrenergic receptors, causing vasoconstriction. So if you want to like give it like a max dose of dopa, it's going to be a pressor. And a lot of times we give this, we don't see this very often unless someone has like severe renal disease. Sometimes we give dopamine just because some pressors might be too strong for the patient. So we give dopamine for somebody that's like in heart failure, just for like the benefits of it. It's the very cool drug when you think about it. Like when you think of dopamine, you don't think of cardiac medication to begin with. You think of the brain, certain hormones, things like that. But dopamine is actually really cool.
I saw a handful of times coming out of the cath lab on dopamine sometimes. From all the pressors, I think this is the one that I've seen the least. Mm-hmm. So a handful of times only. Dopamine, maybe it's not popular as much. Dobutamine is also another one. It's more of an inotrope, so it's not really a pressor to be covered in this episode. But I think I saw that a handful of times as well.
Yeah, they prefer usually Primacor over dobutamine.
Primacor?
Yeah, Primacor is a little more popular.
So Milrinone, right? That's another one.
Same thing. It's Primacor, Milrinone is the same thing.
Okay.
Yeah.
There we go. Freaking CVICU nurse right here, Petey.
But dopamine's cool. Like I said, it's not used very often because it's not very strong at what it does. And usually, if you're going to lean to a pressor, dopamine's better stuff out there. Yeah, to be more efficient and not have as widespread effects, because dopamine is going to give you more systemic effects than all the other ones because it's just more widely available in our bodies. But it's just really cool to see that like how these pressures work and why some physicians use one over the other. And that's something you're not going to learn right away. You're probably going to start kind of figuring it out maybe over a year in your ICU, right? Because you're still kind of trying to hammer things down before you kind of understand these concepts and why we do one thing over the other. But yeah, and if this thing sounds confusing to you guys, it's going to get simpler. You just got to hammer it down a little bit more.
Or you just got to get exposed to it. You're not going to learn everything by listening to us or reading your damn nursing school book, or you want to go to ICU, but you're afraid because you don't know a lot of stuff. Well, the only way you're going to learn is doing the damn thing. Just like us learning activities, right? You're not going to know the sport till you go get your hands wet and you get your feet wet. Just like surfing, right? It's all good. I could stand up on the board on the beach, on the sand, but then you get into the water and just the whole dynamic's different, man. Right. You can't explain how to do it. You just got to go do it.
Yeah, the best way to learn is you doing it yourself. We don't even teach you so much. Just imagine how much you learn in lecture compared to how much you've learned in nursing school, or not nursing school, but in your hospital.
Hell
substantially more. You learn more your first 6 months as a nurse than you do all of nursing school.
And the way we went these pressors, we started from the least severe one to the most severe one. So we went Norepinephrine. If I were a nurse taking care of a sick patient, this is the way drips would be kind of ordered.
If you lived in a perfect world, this is the way pressors would go.
Yeah. I'll give you the way they should be ordered, and then I'll give you the way that they are ordered. So usually it would be Neo, then maybe we could do Vaso, Levo, and Epi when it comes to how, severity, correct? But usually they're like this. Norepinephrine, so Levo-fed. Then they usually go into Vaso after that. After Vaso, they go to Norepinephrine, and after that, we'll do epinephrine. Dopamine, I don't think they don't add 5 pressors. If the patient's on 4 pressors, we're kind of calling it, or we're not going to do anything more than that, because there's really literally nothing more than that we can do.
And most patients don't require more than 1 pressor, because guys, remember, we're titrating these. It's not one standard dose, except for maybe the Vaso. They might want to keep it as a standard dose of 0.03 or 0.02 or 0.04. But for Levo, for Neo, we're titrating them. Right, so you have a lot of leeway to go before you start another pressor. And we're not saying that, hey, before you start another pressor, let's max out the first one. Usually we don't max out the first one. Usually if you're getting up in the higher tiers, we're just going to add another one before we max out any kind of pressor.
Yeah, it's like, great point that you brought up. So it's like levo, right? We're titrating levo fed doses, 1 mic to 20 mics. And let's just say we're in ICU, time's going by, patient's up to 12 mics. Well, I still have that 8 mics of leeway. Well, let's get another pressor on. So we'll add the vaso. And then vaso's maxed out, and levo fed I'm kind of playing with, depends on what's happening. The perfect world, A-line is great. If you don't have an A-line, that blood pressure cuff is going off every 15 minutes on the patient's hand, usually, and you're basing it off that. So map looks good. Let's just say I'm on 10 mics of levofed. I'm looking at the blood pressure. Blood pressure is 120/80. My map is like 65, 66. Okay, I'll titrate down. I'll go down by 1, maybe by 2. 50 minutes go by. I'm looking, damn, I went down by 2 mics. Blood pressure is 90/60. Okay, I'm going to go back on that mic and see what happens. And that's just the game that you're playing in the ICU. Sometimes you're diuresing the patient because they're fluid overloaded. So, as the night's going by, maybe you'll be adding a little bit of levo because we're trying to dehydrate the patient to offload the heart and help with the cardiac output. It's freaking cool, man. I love this shit.
It's interesting, right? And then we don't titrate this based on how we're feeling. There's usually the most standard kind of titration guidelines is you're going to want to keep a systolic over 90 usually and a map above 65, because if you drop systolic below 90, your map's probably going to be below 65 as well, right? So anything really below 65, 60, you're going to kind of hinder renal perfusion and organ perfusion. So that's why we kind of want that 65 range or above, because we want everything to be perfused properly, not only your blood pressure is showing a nice number, right? And it's cool, and I don't know. This is like if you think about it in nursing school, you didn't think you'd be titrating this much drips and kind of have an understanding of this vasopressor, and in general, before you hit ICU rotation, you're not gonna have any kind of experience really with titrations, except maybe insulin drip. Do they have insulin drip on med floors?
No, bro.
I'm not sure,
because that's DKA usually, and they go up to the ICU. If anything, some nurses will do cardizem, diltiazem. They'll be titrating that. That's for high heart rate.
Blood pressure.
Also, if you have chest pain or heart attack, they'll start the patient on a nitro drip in a different unit. And depends what happens. Let's just say the previous hospital I worked at, the PCU or step down ICU was able to start nitroglycerin. As soon as they went above 20 mics, we have to transfer care to the ICU because it's higher concentration.
Yeah, besides narcotics, your vasopressors are going to be the strongest medicines you're ever going to push in your life.
Yep.
I guess you get paralytics are super strong too. Obviously, sedation is super strong too. But you're not really pushing sedation. It's continuous. Or so is vasopressors are also continuous. But titration wise, those medications are going to be your go-to.
I think I would also word that it's the most important to be on top of. So nursing considerations with pressors. If your bottle of fentanyl runs dry or propofol and your pump is beeping, okay, patient might wake up. He might, the vent might be beeping a little bit, but then you could sedate him again. When your pressors run dry, you better be freaking scrambling, calling pharmacy. You better be running to that damn Pyxis because that patient's blood pressure is dropping. And sometimes it's damn freaking quick. And that's a pet peeve too when we talk about don't run your tubing dry. It's okay for other things because if it's a bag of saline, whatever, I'll push a saline, I'll get the air bubbles out. But when my pressors are freaking dry, that's a huge concern because now my patient is literally at risk because they're depending on his medication.
Yeah. I'm glad you said that. When you run out of sedation, your patient's freaking out. Well, guess what? When he's freaking out, he's still alive.
Right.
Now you can do a neurostat.
I could correct that shit. This I can't correct if the patient's dead.
Yeah, there's just sedation vacation. You got your sedation vacation for the shift. Patient moves all extremities. He's yelling, he's coughing, he's choking on the vent. But when your blood pressure is dropping, and then you come into the room and you have barely any of the drip left, and you're scrambling to get the drip, and your pressures are low 80s, high 70s, over 40s, 30s. You're scrambling, and you can't raise it super quick either. Because your blood pressure goes from systolic of 70 to a systolic of 190, 210. Guess what? What if the dude just strokes out?
Yeah.
Compared to when you're pushing, when you get sedation runs dry, You could go in the room, push a little probe, give him a little bolus, and then he comes down. Your blood pressure might come down with it, but then you can always up titrate, and you kind of have, like, it's expected. Your blood pressure is expected to come down when you sedate somebody, right? But when you're titrating a drip of levo, it affects everyone different, right? So 2 mics might seem like no big deal, but guess what? That blood pressure might shoot up real quick, and you don't got really time to be scrambling around when you're fucking with the blood pressure.
Yep, you gotta have your shit straight. I also wanted to mention like the first time I got off orientation from the ICU in my first like staff job, my first patient was on 3 freaking pressors, and she was in her 40s. She got a PE, dude, and she was in nursing school. I felt so bad taking care of this person, and my freaking one of my pressors ran dry. Like, I freaking freaked out, dude. I was like one of those nurses where, you get out of the room and you have like that oh shit face. One of the nurses where I think Jess was like, "What's wrong?" And I'm like, my pressors are dry. And it's like, yeah, it's freaking scary once it, first happens to you. And then you just like, you learn to always check your drips. And you should be always doing that when you start your shift. Yeah. Even a med-surg nurse, go check. If it says 900 in the volume, but there's only 500 in the bag, titrate that back to what it was. Right. Because then you're gonna have that issue of the pump beeping, and you gotta, you know the drill, man. Yeah. I hate tubing running dry. Right, that's dude. Like, it's my thing.
And I hate nurses that put 250 for volume in a bag that has 250. Like, I know you're going home, but just save me the fucking headache and the hassle. Put that to like 230 to 220 instead of 250, so I have some leeway there.
Yes, especially the pressors.
Exactly. If you're not gonna get the bag for me, and you're one of those nurses that puts 250 and 250, and you see that there's 30 mLs left, and the pump is programmed to have 30 mLs left, bump it down for me at least to like 20. Yeah. Just in case I forget or I don't have enough time.
Yeah, just because you're listening to this and you're going to take this piece of advice, that is already going to make you a better nurse than most people that don't know about this. And another reason why it's not only about tubing running dry, let's just say you have a medication that is only from the pharmacy. Well, if the machine goes off and I could put in an extra 50 cc's, I could go meta request, and I have that extra hour, 30 minutes, hour and a half before pharmacy sends that medication to me. And Matt's happy because I could hang it. My patient's happy.
Because you're alive.
Happy shift. Going home, I'm gonna smile, get the laughies, go to gym, go to sleep.
There you go. Beautiful, dude.
Beautiful story to wrap.
Beautiful story, beautiful podcast, beautiful day. Thank you guys so much for tuning in. Anything else you want to get off your chest, Matt? Any more vasopressor stories you want to go with?
Nah, man. I mean, I have at this point it becomes like, hey, just go to ICU. My patient's on pressors, and it is what it is, right? It's like second nature to us. Yeah. Like first time you're a nurse, you're like freaking out. You got a titrate, but now it's like, okay, my patient's on this and that.
And that feels like actual nursing, because you have those days where patient in the ICU, but it's like a
ETOH.
Yeah, or it's like a step down patient. They're just here for closer monitoring. You're not really titrating any kind of drips. You're just kind of turning, wiping ass. You give a sedationification and you move on with your shift. Compared to when you have pressors, and always when you have pressors, the goal is to keep in those parameters and you want to get them off it all the time, right? That's when you feel like an actual nurse. Like, damn, I'm actually, adjusting something. I see the numbers change.
It's also cool. That adrenaline, man. Mm-hmm. Like, I just feel like one of those nurses that, like, shit's hitting the fan. I got to be on top of my game. Because if I'm not, well, that is your responsibility, Matt. I don't care if you were a good charter, but you let this patient go, and like your skills really come out to shine. And that's when, like, in those situations, you can find out who is like a good nurse from the bad nurse. And that's when you have that like freaking team, us going like to work, who's on the unit. It's going to be a good shift. Yeah. Shit's going to be taken care of. Right. We are that team, Yeah,
shit business. All right, guys. Thank you so much. Patreon is out officially, right? Well, I don't know, but it's unofficially out.
Just say it. Don't butt yourself.
Yeah, I'm going to say it's out unofficially, but you guys can check it out. We already have some videos there for you. Still a few kinks that we're still straightening out. But yeah, YouTube's going great. Thank you guys so much. If you guys sign up for Patreon, great content. We have something really nursing based. We're doing our like drives from our hospital to home. So we're doing like little shift debriefments that we're going through, a little more nursing based. We also have extra episodes out for you guys, more of just like just talking about our personal selves.
Shit and talking, just, like, talking about stuff. Whatever, conspiracies, aliens. Add anything to the sauce of what's happening in the world, you will find it on there.
Yeah, and shop is open, guys. We're bringing in more products. Some cool shirts going to be on there. Some cool merch. There's a couple of you guys are watching YouTube is available It's a very good flask. And if you guys are listening on Spotify or Apple Podcasts, don't forget to check out our YouTube. Matt's hair's on fleek.
And we're going to have some cool shirts coming out. The designs are in the progress, so keep checking out the store. It's not only going to be these awesome shirts with their logos. It's going to be, I'm going to spill it, man.
Don't do it, dude.
Let
it be a drop.
Dude, these nurses or whoever's listening right now, they've been listening to us for over 40 minutes. They deserve to know. So guess what? We're going to have a shirt that's coming out that says Frontline Warriors. I highly suggest you buying one.
Yeah, because we are frontline warriors. Not workers, or warriors.
See you next week.
Peace.